Alright, looks like it's recording. Alright. Okay, so I'm gonna go through this real quick. I'm assuming y'all can hear me okay. Like I said, I don't like the way this is presenting on my screen. I got little bitty tabs all over the place, and they're very small. And I'm hoping this thing says I'm recording. Hopefully it records it and saves it. All right, so real quick, let me, of course, I can't advance my slides. Give me a second, let me figure this out. Oh, hell. Sorry guys, I'm not sure how to advance the slide here. All right. Give me 1 minute. Figure this out. All right, got it now. All right, so chapter 27. Okay, so some things to talk about here. Review what the law of inertia is. I'm going to explain some concepts to you guys. If it's stuff that y'all can just review because it's a bold term or something like that, I'm not going to really explain it. Okay, but I will explain some of the other stuff. All right, so some things y'all need to know. The impacts, okay? Know that 3 impacts occur when you're talking about something like this, like a car hitting a tree. Okay, so the car hits the tree, then the body collides with an object in the vehicle. So like you see on the steering wheel, there's colliding with the steering wheel, and then your organs collide within your body. Okay, so just know that there's 3 collisions that are occurring here, or 3 impacts. Okay. So some common things that you're going to see right here. Well, before I get to that, you're going to hear some mechanisms of injury and also some other things like when they talk about a death of another occupant in the vehicle. All right, these are high index of suspicions on patients, meaning if you have 2 patients in the same vehicle and one of the occupants is dead, then you have to have a high suspicion that the other patient may have something seriously wrong with them, even though it's not presenting right away. Okay. Another one is an unresponsive patient or a patient with altered mental status. Um, Intrusion greater than 12 inches into the occupancy compartment of the vehicle. So if there's greater than 12 inches, that's a high index of suspicion. Also, if there's greater than 18 inches anywhere in the vehicle. All right. So 18 inches intrusion anywhere along the vehicle, that should give you a high index of suspicion that something could be seriously wrong with your patient. An ejection from a motor vehicle and the that's pretty much all these on that page. Okay, so if you have a patient that's ejected, doesn't look like he's hurt too bad, you really need to keep an eye on it. All right, so this slide here, when it talks about different types of collisions, right here what they're talking about is up and over and down and under injuries. Okay, so an understrained driver in the middle frame. See if I can use a pen without totally messing this up. Okay, all right, here we go. It's highlighted in yellow. This is what's called up and over. Okay, so he's going up and over the steering wheel. You have impacts to the head, neck, chest, abdomen, contacting the steering wheel and the windshield. Okay, so that's common injury patterns. Down and under is the other one here. And you can see that there's a lot of lower extremity injuries, okay? Injuries to the knee, the hips, maybe the femur, okay? And then also some possible spinal injuries, okay? So if you hear up and over, down and under, and common injury patterns associated, this is what they're talking about, okay? I go back to my pointer. All right, well, boy, I do not like the way this thing presents. So now I got to erase all this stuff from slide to slide. All right, no more drawing. Okay. Oh, now where'd my stuff go? All right. Okay, so we talk about a rollover. This is probably the most severe of all impacts because so many things can happen in a rollover. All right, what y'all have to understand is when airbags deploy, okay, they rapidly deploy and then deflate. So in a rollover, if they rapidly inflate and then deflate, the vehicle's still rolling, so now you've lost that protection. Okay, so this is where you can see much more of the different injury patterns all over the body. Now, that's if this person stays in the vehicle. Okay, a lot of times unrestrained rollovers, they get ejected, and you can go on YouTube or anything like that, and a lot of times they do it with mannequins. Like they'll roll a vehicle and then you just see them coming flying out of the vehicle. Well, people do the same thing when they're not restrained. Okay. All right, let me see. Let me look at some other stuff in the book. If you hear the term a paper bag syndrome, all that means is basically you bust your lungs. Okay, you know, you're about to impact, you take that big deep breath and impact and basically cause a pneumothorax. Okay, just because you took that big deep breath, filled your lungs up, impacted, and it caused a pneumothorax. So if you hear the paper bag syndrome or paper bag effect, that's what they're talking about. All right, let's see. All right. Things you have to be careful about: falls greater than 20 feet. That's another high index of suspicion. Okay. Also, if a patient lands on their feet, lands straight up and down, you have that shock wave that goes up the spine. So you can have potential spinal fractures just by somebody landing on their feet because of all the jarring that happens. Penetrating wounds. Okay. So right here, they're talking about, and I don't know if y'all can see the words at the bottom of the screen. It's hard to see. It looks like y'all can. Okay. So it talks about the drag. Okay. Drag is what's slowing the bullet down. Now, air can do that. Okay. Eventually, there's going to be enough drag just by the air that the bullet's going to drop and fall and stop. It doesn't just keep going on forever. Okay. So anything that bullet hits causes a drag. All right. The profile really just depends on how big that impact is and how big that projectile is. All right, is how big your profile is going to be or your entry. The cavitation, man, I wish, okay, I'm gonna have to use my pen here. Let me get a different color. Okay. All right. So when you talk about cavitation, okay, they're talking about the shock wave that radiates away from the projectile, okay? So it's that pressure wave coming out of it, all right? Now, depending on the speed of that projectile, depends on how big of a pressure wave you're going to have, or how much cavitation and how much damage. So if you see right here, it's talking about high velocity, medium in energy, okay? So they're probably talking about like a handgun for this projectile, all right? And a rifle for, oh, I don't know what the heck I just did, okay? All right, probably a rifle, that's a high velocity weapon. So that projectile's traveling at a much greater speed. It's going to cause a much bigger pressure wave on impact. So it's going to cause more damage, okay? Where that low or medium velocity, you know, you might break the bone right here, okay? Where this high velocity, you can just see that it just totally shatters it. Okay, so speed is a big deal when you're talking about high and low velocity weapons. Okay, now this says a medium to high, a low velocity. That's kind of like a bow and arrow or a stab wound. Okay, it's not traveling that fast. It can't cause a lot of cavitation. Tell you what, let me see if I can drag this thing. Yeah. Okay. All right. Moving on. Fragmentation. Some bullets are made to fragment. Okay, so on impact, they break up into little pieces. It causes more damage. Some bullets don't. They stay pretty much formed. Okay, so that's all fragmentation means. It just breaks off. You know, some bullets are designed, what they say is not to leave the body. When it hits, it fragments and just causes all kind of damage. All right, get rid of all this. This is going to slow me down till I learn how to use this thing. Okay, when we talk about blast injuries, okay, 4 different phases to a blast injury. The primary one is the pressure wave, okay? So you can see right here, the pressure wave is what's causing some injuries to like hollow organs. That's where you have your, you know, your eardrums may burst. You may actually have some of your intestines, they don't explode, but it could at least split or something like that just from that strong pressure wave hitting you. The secondary injury is usually due to flying debris, okay? So on the secondary one, that's where you're going to have shrapnel from, that's where you're going to have shrapnel that's from the blast site, okay? So that can either be from the actual bomb or whatever caused it, or just whatever's been picked up and thrown, okay? So if you have something impaled in a patient, that's due to the secondary injury of the blast phase, all right? The third phase, or tertiary, is the patient being thrown into something, thrown into a wall, thrown into the ground, whatever it may be. That's the tertiary effect. Okay. Now the fourth, or the quinary injury, is usually due to maybe some type of harmful chemicals, gases, stuff like that that the patient is exposed to. So y'all need to know these 3 phases, okay? The pressure wave is the first. Hollow organs are affected. The second is flying debris. That's where you may have impaled objects. The third one is being thrown into something. The fourth one is possible chemical or gases exposure, okay? All right. Now let's talk about the multi-system trauma patient, all right? let me get to, all right. So here's some indications of scene time of 10 minutes or less in rapid trauma. Now, I'm not going to go through all these, okay? But you can see that they're pretty high index of suspicion or pretty high impact injuries, okay? So you can see a flailed chest, pneumothorax, fractured pelvis, 2 or more proximal long bone fractures. So proximal, remember, that'll be like your humerus or your femurs. That's proximal long bones. All right, seizure activity, so on and so forth. All right, so that's when you need to try to get off the scene in 10 minutes. Now, if somebody falls and breaks their arm, that's not multi-system trauma. All right, you don't have to get off the scene in 10 minutes for that. All right, somebody gets stabbed in the foot. We don't need to get off scene in 10 minutes or less. Okay, it has to be something that's has a great impact on your patient, or what we call multi-system. They have an airway issue and a bleeding issue, or a lung issue, a hole in the chest. Okay, several systems are involved. That's when we have to keep that scene time less than 10 minutes. All right, hopefully by now y'all have covered this stuff. Arterial bleeds, that's bright red and spurting. So when you talked about trauma assessment, remember, as you find this, you have to take care of it. Pressure dressing, tourniquet. All right. Venous bleeding is slow and steady. It's dark red in color. Maybe sometimes you can come back to it until you finish your assessment. But venous bleeding can be severe. We do need to take care of it. And then you have capillary bleeding. So that's your like brush burns, road rash, that type stuff, um, where you just kind of scrape the surface and have that very minor bleeding. That's nothing that we usually have to take care of other than protecting it from becoming contaminated. All right, a nosebleed, okay, or what we call epistaxis. All right, I think we've moved on. Yes, moved on to chapter 28. Okay, so a nosebleed, or what we call epistaxis, um, you should have your patient sit forward, pinch the nose, put ice if necessary, or if you have it available, ice pack will work. All right, and make sure you also tell your patient not to swallow blood. We don't digest blood very well, so it makes you nauseated, so you may have some vomiting. So have them spit it out, spit it in something, give them the suction catheter to spit in, what have you. But that's basically what epistaxis is, okay? Is a nosebleed. All right, so let me kind of go on here. Let me look in the book, make sure that there's nothing. If you hear the term hemostatic agent, that's usually just some type of, it's either a powder or it's a gauze that's has this, they call it, one of the brand names, Quick Clot, embedded in it. And basically what you do is you pour it into a wound that's bleeding. It generates a lot of heat and cauterizes and clots that wound off rather quick. You're not going to see this a lot in pre-hospital. They use it in the military sometimes. But tourniquets tend to be the treatment of choice when you can't stop bleeding. All right, just continuing on. All right, so we're talking about internal bleeding. All right, some signs and symptoms. So remember, when you have the early stages of shock, this first bullet point, anxiousness, restlessness, combativeness, all right? What I like to say is the patient becomes very fidgety. They can't keep still. They keep moving around. They want to sit up. They get down, okay? Heart rate is rapid, all right? That's some very early signs of shock, okay? So even though it's not showing itself right away, that's some very early signs. Okay, so you can read some of these other ones. All right. Now, as far as a blood pressure, um, okay, once blood pressure starts to fall, that's a late sign of shock. Okay, falling blood pressure is a late sign, not an early sign. All right, of course, pale, cool, clammy skin, dropping blood pressure, like I said, is a late sign of shock right here. Okay. All right, so this is kind of showing the cycle of hemorrhagic shock. Remember, there's many other different categories of shock. This is hemorrhagic or hypovolemia, okay, or hypovolemic shock. You're losing volume, all right? So remember, everything starts to compensate. Everything goes up, epi's released into the body, heart rate goes up, it beats stronger, faster, bronchioles dilate, all right? It's trying to compensate for these baroreceptors determine that we've lost some pressure, so the body's going to try to use the sympathetic nervous system to increase pressure, okay? But as we keep losing volume, things start to malfunction, all right? So after a while, uh, the patient had been tachycardic. Now it's going to become, you're going to see heart rate start to drop, okay? Blood pressure starts to drop. The brain becomes ischemic because it's not getting blood flow. Remember, blood flow carries oxygen, so you're going to have a decreased level of consciousness, unconsciousness, and it just gets further and further to where if we don't plug the hole and get more volume in them, all that tissue is going to die, and then the patient's going to die. Okay. So here's some terms y'all need to know. A contusion is a bruise, right? It's just a bruise. Now, that black and blue discoloration is called ecchymosis. So if I say you see ecchymosis on your patient, it just means they have a bruise. Okay. Now, hematoma is a raised bruise. All right. I'm sure everybody's got a knot on their head before. Got a big raised area. Okay. So that's what a hematoma is. All right. It's basically, think of it as like a raised bruise. There's just more bleeding into the tissue. Okay. And then a crush injury, that's where maybe something heavy falls on an extremity. Okay, it doesn't necessarily have to be an extremity, but if it falls on the arm and crushes it, okay, it damages all these blood vessels. So you have bleeding into that tissue, into the soft tissue. Well, after a while, the skin will get so tight that the pressure will build up and there's nowhere else for that pressure to go. It'll start putting pressure on the blood vessels and the nerves, causing more damage in the arm. Okay, so that's what a crush injury is. Here are some other terms. An abrasion, okay, talked about abrasion, road rash, that's capillary bleeding, all right. I'm sure everybody knows what a laceration is. Now, when they talk about a linear laceration versus stellate or irregular, a linear laceration is like a clean cut, okay, straight line. Stellate just means it's very jagged. All right. So just like this leg wound in this bottom right picture, kind of, that's a stellate. Okay. It's very just jaggedy and chewed up pretty good. Now, an avulsion, typically that's a piece of skin that's been torn away, but it's still connected a little bit by a flap and still getting some blood flow. Okay. That's what an avulsion is. Now, you can totally avulse a piece of tissue where the whole thing comes off. But typically when they talk about an avulsion, it's just a flap of skin. Okay, it's been torn away, it's still connected, maybe still getting some blood flow. Amputations, everybody should know what that is. Okay, get cut off. Now, if you notice in this picture, I don't know how well y'all see in this screen. I don't know how it's presenting on your screens. You can see that there's very little blood loss with some of these amputations. And a lot of times that's because those little blood vessels basically tamponade off. They clamp shut, okay? And you just don't see a lot of bleeding. When you're talking about puncture wounds, by now hopefully y'all talked about like a puncture wound to the chest. you should put occlusive dressing over it. Occlusive dressing is something that air can't pass through. Tape it on 3 sides. Now, if it's on the neck or the abdomen, you still have to put an occlusive dressing. You may want to put an absorbent material in between it, okay? But on the neck and the abdomen, you're going to tape it on all 4 sides. All right? All right, let me see. I'm trying to keep up in my book here. All right, so here's some different dressings and bandages. So you need to know the term of each one, okay? A dressing covers the wound. A bandage is what's used to secure it into place. That's really what y'all need to know about dressings and bandages. All right, so let's talk about anatomy of the skin, okay? We talk more about this in burns, okay? But just know basically 3 levels. You have the epidermic or epidermis layer. That's your outermost layer, which provides a watertight, resilient barrier from the external environment. The second layer, the dermis, that's the thickest part. That's where I like to call it, that's where all the meat and potatoes is, all right? That's where your blood vessels are, your nerve endings, your hair follicles, your sweat glands. All that's contained in the dermal layer, all right? Now, below that is the hypodermis or subcutaneous level. That's your fat layer, all right? Or what you may hear the term adipose tissue. That just means the fat layer, okay? Now you can see all the things that the skin is responsible for. I'm not going to go through all these, okay? Yes, it forms a watertight barrier. It does regulate your temperature, keeps bad things out, okay? Like microorganisms, all right? All that stuff. So I'm not going to cover all those. It's listed in your book. So actually we're in chapter 29 now. All right, so now we get into some important stuff that y'all need to understand, and that's burns, okay? You'll need to know how to classify each type of burn, all right? So you have a 1st degree, 2nd degree, 3rd degree burn. They've kind of renamed them to superficial, partial thickness, and full thickness, okay? If you hear the term of one, you just need to correlate it with the other. So you just need to know a 2nd degree and a partial thickness mean the same thing, all right? All right, so in a 1st degree, that's the epidermal layer that's affected. That's like a sunburn, okay? Just the outermost layer is affected. It's red, painful, no blistering, tender. Now, a partial thickness or 2nd degree, usually you have blistering and intense pain, okay? The skin can be white to red, and it can be moist and mottled, okay? Mottled just means blotchy, all right? So you can see on the little picture here. Let me get my little ink pen ready again. Okay, so the dermal layer is right below the epidermis. My pen's kind of thick, and then you can see it's kind of like this. So you see the burn area here, okay, that little red area. Sometimes they classify a 2nd degree into what's called a superficial partial thickness and a deep partial thickness, okay? All the superficial partial thickness means is that the upper part of the dermis is affected, okay? So that's, you know, maybe up at this layer. A deep partial thickness is a little deeper down the skin. Now, when you look at it, you're not going to be able to distinguish the two, okay? Just know that those things exist. Superficial partial and deep partial are both 2nd degree, okay? It's just that dermal layer is a little thicker and they'll separate it sometimes. Full thickness or 3rd degree burns, you'll see a leathery appearance, charring, dark brown or white. It's hard to touch, but there's no pain in the area because all those little nerve endings have been burned away. I'm going to shut my door. Cleaning crews here, and they're starting to vacuum. They're going to make a lot of racket. All right, maybe that'll quiet them down a little bit. All right, so just realize there's not a third degree burn where you're not going to have pain, because you also have second degree and first degree radiating away from a third degree. You won't have an isolated third degree burn. You still got some second degree burns around it and stuff like that. So there will be some pain even though the patient has a third degree. And those are called full thickness. Okay. All right, so here's some examples. You can see first degree burn or superficial burn. You can see the redness to the neck here. The guy on the right, that's a partial thickness. Y'all can obviously see the blistering, so that's a second degree burn. Now at the bottom, this guy's been burned pretty bad. He's got full thickness. He has actually some blackening of the skin, and you call that eschar. It's called eschar, okay? When you see that dark charred area of the skin. Now, this causes a severe problem because what happens is the skin becomes so hard and non-pliable that the patient's chest can't expand. The skin's not elastic. It doesn't stretch like it used to. So they'll have some problems with tidal volume. So you can see on the bottom right, they'll do something called an eschorotomy. All right. This is actually called, they call it the Roman chest plate, where they make these deep incisions so that the chest can expand. All right, because the skin is just so tight and so hard that the chest can't expand and it can't get good respirations or ventilations. So they do what's called an eschorotomy and cut the skin open to allow that to happen. Y'all can Google eschorotomy. There's all kind of pictures out there. And basically they're just slicing the skin open, okay, to allow that swelling to occur. All right, here's some critical burns. Y'all don't need to, anytime y'all see a percentage, don't worry about studying that percentage, okay? But y'all do need to know full thickness burns involving the hands, feet, face, eyes, ears, or genitalia is a critical burn, okay? It's considered critical. Now, those are very vascular areas. Of course, to your face, we could have some airway burns and have some respiratory problems. But like your hands, your feet, they're very vascular. Not only that is we could lose function to them, okay? The genitalia, that's another one. You have severe burns to your genitalia. First, you're gonna have to explain how the hell you burn your genitalia, but you can have trouble voiding, okay? Can't urinate, defecate, so that can cause some severe issues. Burns associated with the respiratory tract, full thickness burns covering more than 10%. I'm not going to cover all these just because they do have those percentages, and I don't want y'all to focus too much on that. Okay, but you can see second degree burns more than 25% in adults, second degree in greater than 20 in children, less than 10 adults, greater than 50. Okay, so you can see it's getting a little complicated. Electrical burns, high voltage burns, burns complicated by fractures or major trauma. What y'all need to understand also is when you have burns with trauma, we treat the trauma first. Trauma is going to kill the patient before the burn will, all right? Unless it's an airway involved burn. So if you have a trauma patient that is burned, you can bring them to a trauma center. Okay, the trauma center and the burn center are not the same place. They go to the trauma center first. Okay, treat the trauma first. Circumferential burns to any body part. Okay, all a circumferential burn means is it's burned all the way around something. So all the way around your arm, your leg, your chest. Obviously, you saw the guy with the chest, and he had that eschorotomy done. That is a critical burn. Okay. Rule of nines. This is something y'all have to understand. There's several questions on the exam. I'm going to try to explain this without confusing the heck out of you. So I need y'all to fully understand the rule of nines. I need to trying to make this ink pen draw a little thinner, but I don't guess it will. Okay. All right. Now, the reason I hate the way they explain it is because they always show you an adult view anterior posterior, and then they show you a child of just an anterior view. And it gets confusing to some people. So I need y'all to kind of pay attention to what I'm telling you. Okay. All right. The head and neck. All right. Why isn't my pen taking over here? Okay. Nope, still not doing it. Come on. I'm trying to draw. Somebody take, hang on. All right. Okay, so head and neck all the way around is 9%. Okay, all the way around, 9%. Now, what y'all need to understand is when y'all take a test or y'all answering a question about burns and it's describing a body part, pay attention to what it's describing. Okay, so in this case, it's 9% all the way around. What do you think if it just said your patient had burns to the face? All right. Now the problem is I don't know how to communicate with you guys. I don't see where chat is. Anyway, okay, so I'm moving on because I can't figure out how to see what y'all are chatting. All right. So it would be cutting half to 4.5. All right. So 9 all the way around. If they see you have burns to the face, cut it in half to 4.5. All right. Now, when you're talking about the trunk or the torso, that is from there to there. Okay. Now, the whole thing is 18% on the front and the back. Once again, y'all need to pay attention when they describe a body part that's burned. All right. I'm not going to say they're trying to trick you. All right. But if they say your patient has burns to the chest, then they're only talking about this portion. Okay. So now it's only 9%. Right? Okay. The abdomen, they say you have burns to that. That's 9%. Right? Let me close my 9 up there. Okay, Langston, I saw that chat thing pop up. Let's see. Oh, there we go. Okay, I found it. Okay, now I can see y'all chatting a little bit. I really don't like this feature. Okay. All right. Give me a second. Okay. So pay attention to what the question's asking. Okay. So if you have circumferential burns, if you had circumferential burns to the entire torso, that'd be a total of 36, right? Because it would be 18 on the front, 18 on the back, 36 altogether. Okay. Now, the genitalia, 1%. Okay. 1%. Now, lower extremities. Each leg all the way around is 18%. Once again, pay attention. If you say you have second-degree burns to the anterior portion of the left leg, all right? Anterior portion of the left leg, what is your percentage? Pop it up in the chat because I can see y'all chat now. Figured out how to find it. Anterior portion of the left leg would be what percent? Anybody? Y'all still there? Can y'all hear me? Have I been talking to nobody? Okay, there we go. All right, Emily, very good. 9%, right? Because it's only talking about the front of the leg, anterior portion. All right? So please, 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 when you read the question, make sure you understand what body part they're talking about. Like I said, I'm going to recap. The torso is chest and abdomen, but they may say burns to the chest or burns to the abdomen. So that would be 9 and 9. Okay? All right. Another thing too, when you're talking about the rule of nines, okay, you're only referring to second and third degree burns. First degree burns are not included in the rule of nines. Only second and third degree burns. So if they give you third degree burns to the leg, second degree burns to the arm, first degree burns to the face, don't count the first degree burns to the face. All right, it's only the second, third degree burns. All right, the arms are 9% all the way around. Okay, so arms are 9% all the way around, legs are 18 all the way around. Okay, all right, so hopefully you understand an adult. Head, recap, 9 all the way around. Torso, 18 on the front, 18 on the back. Don't forget to split the chest and abdomen if they ask you a question about it. Genitalia, 1%. Legs, all the way around, 18%. Arms, all the way around, 9. Okay? All right, so let's move on to the kid. All right. The only thing that changes on the kid are the head and the legs. Everything else stays the same. The head becomes 18% all the way around. Unlike the adult, that's 9, the kid becomes 18. So if there's burn to the face of a kid, it's 9, okay? The legs become 14%, not 18. That's the only change between an adult and a kid, all right? But they're important changes, so don't forget them, okay? Head and legs, the only thing change. Arms, abdomen, chest, back, torso, all that stuff stays the same. Okay? All right. I hope I somewhat explained that fairly well. Okay. So how do we treat them? Remove the patient from the source of the burn and stop the burning process. If their skin is smoldering, we want to put water on it. We want to stop the burn process. Okay? But we have to be very careful not to make our patients hypothermic. Remember, that regulates temperature, your skin. Okay? So yes, it feels good to put like something cool on a burn, but if they're burned in a large surface area, you can make that patient hypothermic. So typically, we treat burns with dry, sterile dressings, unless it's a very small percentage of burn. Okay? Dry, sterile dressings. Establish, maintain an airway, adequate breathing and oxygenation. Classify the severity of the burn and transport immediately if critical. Cover the burn with a dry, sterile dressing. All right, keep the patient warm because, like I said, they could lose body temperature with that burn area. And transport to appropriate facility. You want to transport these to burn facilities. Now, burn facilities are not all over the place. There's one here in Baton Rouge, there's one in Lafayette, I think the other one's in Beaumont, there's one in New Orleans, and one in Shreveport. Okay, so most of these burn centers, unless your patient has airway involvement and are not critical, will let you transport a good distance to get to a burn center. Okay. So remember though, there's trauma associated with it. We treat the trauma first. Okay, treat the trauma first. All right, I think we've kind of moved out of the burn chapter into chapter 30. Yeah, okay. All right, simple definition of a ligament and a tendon. Okay, ligaments are bone to bone, tendon is muscle to bone. Just know the definition. All right. Um, so Okay, so right here, the definition of the axial skeleton, okay, is comprised of the head, thorax, and vertebral column, okay? That is the axial skeleton. The appendicular skeletal system is made up of the bones in the extremities to include the shoulder girdle and pelvis, all right? So I'm sure y'all have heard of an appendage, okay? Something kind of hanging off. So if you can kind of remember it that way, the appendicular skeletal system is the extremities, shoulder girdle, and pelvis, right? Where the axial is just the head, thorax, and vertebral column. Okay, when we talk about fractures, an open fracture, these used to be referred to, you don't see the terminology much anymore, but a compound fracture is an open fracture. That just means the bone has poked through the wound. Hang on, somebody's calling me. Yeah, I'm still working. Okay, thank you. Okay. Closed fracture, simple, bone's not poking out. Okay. A strain is an injury to the muscle and tendon, possibly caused by overexertion or overstretching. A sprain is an injury to the joint capsule. Okay, so that's where the connective tissue, usually ligaments, are involved. So that's the difference between a strain and a sprain. Okay, dislocation, I'm sure y'all all know that. Okay, you can dislocate your shoulder, your knee, your hip, your elbow. Okay, that just means it kind of comes out of place. Remember, you have a large blood supply in your bones, and you can lose a significant amount of blood. So just for, like right here, you can lose about 1,500 milliliters or 1.5 liters of blood in each femur. So you can lose half your blood volume. Your book actually says you probably could lose more than that. Okay, it just depends on what you read. Um, So also pelvic fractures, you can lose practically your entire blood volume in a pelvic fracture. Okay. Let me just go over some other terms that we learned earlier in class, but I just want to repeat them. Um, Flexion and extension. Remember, flexion, or you're talking about, this is usually like we talked about posturing, okay? Patients flex, they flex in, extend out, okay? And then there's adduction and abduction. Remember, adduction and flexion mean the same. So if you flex your muscle, okay, you're adding it, you bring it into the body, okay? Abduction and extension mean the same thing, moving away, okay? All right, so general rules of splinting. Once again, I hope y'all have been taught splinting already and understand it. Remember, before you apply the splint, you assess motor, pulse, motor, and sensory. Okay. You want to see if that everything is working, and then after you splint, you check it again. Okay. You always immobilize a joint above and below the long bone injury. Cut any clothing away. Um, Cover the wounds to protect them. Um, Just remember, if you have a extremity that you don't have a pulse and it's cyanotic, you can make one attempt to straighten it, to realign the extremity to get blood flow. Never intentionally replace a protruding bone or push it back in. Sometimes it happens just by splinting, or if we do a traction splint, okay, that femur has shifted and we pull that bone back. All right, so if that bone's poking out, the unintentional consequence is when we pull that bone back, it goes back in. Okay. Um, when in doubt, splint, and that's pretty much it. I'm dribbling on myself. Um, A term, crepitus, if you haven't learned already, crepitus just means two broken bones that are rubbing together. You get this kind of crunchy feeling going on. Here's some different splinting materials. Y'all know about spine boards and all that. You have a traction splint, you have a hair traction. Hopefully your instructors have at least showed you what traction splints look like. On the left is the hair traction. Uh, All right, well, it's not letting me draw, but this one on the left is the hair traction, and one all the way to the far right is the Sager splint, and that's typically the one that we're going to use more often now. Okay. All right, so I think we're kind of moving on to the chapter 31 now. Head trauma. Know the different areas of the skull, the main portions. Okay, you got your frontal bone. Okay, frontal here. The parietal, these are on the side of your skull, okay, here. The occipital bone is in the back, okay, it's back here. Some other one important, okay, remember the maxilla, the upper jaw, okay, and then the mandible is the lower jaw. Remember, the mandible is the only moving part of your skull, or at least that should move. If you got a different moving part, you might be in trouble, okay. Mastoid process, that's that bump behind your ear, okay? Temporal bone, y'all can figure that out. Most people know where their temples are, okay? That's really all y'all need to know there. All right, here we want to talk about different layers of the skull. Come on. I don't know why it jumped there. I'm trying to get this doggone pen to work. Okay. All right, so different layers we want to talk about, okay? You need to know the cerebrum or cerebral cortex. That's the gray matter. That's the main part of your brain, okay? The cerebellum, they call that the small brain, okay? This is what is responsible for like coordination and gait, all right? Now, these different layers, you have the dura mater, arachnoid, and pia mater, all right? Now, the pia lines the brain here. Then you have the arachnoid layer, and the dura lines the skull, okay? So an easy way to remember how those layers are located, if you can remember pad from the inside out, okay? Pad from the inside out. So pia, arachnoid, dura. Okay, so it's working this way. Pad from the inside out. Pia, arachnoid, and dura. The arachnoid layer, that's where your cerebral spinal fluid is located, in that area there. Okay. All right. Talking about different skull fractures. Linear, just like a linear laceration. Okay, it's just a straight line. No gross deformity. Depressed skull fracture, that means it's smushy. Okay, you're going to move stuff. An open and closed skull fracture, I mean, you either can see inside or you can't. Okay, if it's open, then one's not worse than the other. Okay, I mean they're both bad, but a closed and a open skull fracture, one's not worse than the other. Basal skull fractures is the floor of the brain. So that, or the skull, it's this way. The floor of the skull this way. It's the thinnest part. Okay. So when you have a basal skull fracture, a lot of times there's leakage of cerebral spinal fluid, or CSF, from the ears, nose, or mouth. And there's ecchymosis, or bruising, around the eyes and behind the ears. Okay, so we talked about this in a few chapters ago. So when you talk around discoloration around the eyes, they call those raccoon eyes. Looks like you got two black eyes. Okay, and then you have some bruising behind the ear on the mastoid process. Okay, and that's all indicative of a basal skull fracture. These are called battle signs, the bruising behind the ears. Okay, guys, we're getting close to the end of this thing. All right, 3 more slides. All right, so let's talk about brain herniation. I kind of mentioned this a minute ago, okay? So remember, we have an enclosed hard object right here, all right? So when there's bleeding in here or swelling, there's nowhere for it to go except down to the brainstem, okay? So that's when you can have some herniation occur. All right, I just noticed Emily asked the question, for an open fracture, does the bone need to be the specific cause? Or does the proximity of the break of skin determine? Okay, Emily, yeah, you're still here. Okay, basically, if you have a break in the skin above a fracture site, you can assume that it's an open fracture or an open wound. Okay, so the bone may be poking out. You may see it. It may have broken through the skin, went back in, but regardless, it's considered an open fracture. Okay, I hope that answered your question. All right, so let's talk about, you're welcome, brain herniation. Okay, so remember it's pushing the brain downward out of the foramen magnum. Okay, remember that hole at the base of your skull that your spinal cord's going through? It compresses the brain stem, destroying vital functions including heartbeat, respirations, and blood pressure. Remember, you damage your brain stem, you're done. Okay, you're done. Cancel Christmas. All right. So signs and symptoms specific to brain herniation. So all these things: dilated, sluggish pupil, one side. So you'll have unequal pupils. Okay. You can have weakness, paralysis, alterations in cognition, or changes in consciousness, and then posturing. Okay. I talked about this a minute ago about flexion and extension posturing. Okay. These are what's known as non-purposeful movements, meaning you inflict pain to your patient. They're not intentionally trying to get away from you. It's just their body's natural response. So if I inflict pain and the patient does this, that's flexion, okay? Or the corticate posturing, my bad, okay? The corticate moving towards the core, all right? Flexion, all right? Now, if they, just like the girl at the bottom, everything's poking out, arms go out, that's extension or the cerebit posturing. Okay? Now, Cushing's reflex happens when you have increased intracranial pressure. Now, they used to call it Cushing's triad because 3 things were happening. okay? Blood pressure goes up, and this is important to know. Blood pressure goes up, heart rate goes down, and respiratory patterns get kind of janky, okay? Meaning you can have some irregular breathing patterns. That's a sign of cushion reflex. So if you read a question and this patient's been in an accident, he's unresponsive, and the blood pressure is 180 over 120, the heart rate is bradycardic, he's got a heart rate of like 60, and they say has an irregular breathing pattern, that's Cushing's reflex, and that's due to intracranial pressure, increased intracranial pressure, okay? All right, so let's talk about some other terms. A concussion is what's called a mild diffuse accidental injury. So it involves stretching, tearing, and shearing of brain tissue. All right. Now, a concussion can present with an altered mental status that progressively improves. If it doesn't improve, something else is going on. So one way to know it's a concussion is when your patient slowly gets better. Now, they could lose consciousness. They might not. Y'all have seen football players on TV get their bell rung and they walk to the wrong sideline or they just do goofy things. Okay. That's a concussion. Um, the thing about concussions is they get better. All right. The patient continuously gets better. Now, these patients will be somewhat irritating to transport sometimes because it's very repetitive questions. All right. It's what happened. A minute later, what happened? What happened? You keep answering the same question. Okay. Now, a contusion, remember, it's just a bruise to the brain. All right. So with a bruise, we can have some swelling in the brain, some other problems start to occur. All right. Now, this is a weird little term, but you need to know what it means. It's called a coup contra coup injury. Well, this one right here. And all a coup contra coup injury means is when you have an impact, let's go this way. So we have impact to the brain here, and we have some damage here. That's the coup injury. The contra coup is when your brain moves in your skull and jiggles and impacts the other side of your, oh, my arrow's not too pretty, of your skull and causes damage over here. So when you hear the term coup contra coup, that's all it means. All right. It's an injury to one side and it travels to the other side. Coup contra coup. All right. Now, one that you definitely need to know is what's a subdural hematoma. Okay. A subdural hematoma is a collection of blood between the dura, remember that is lining the skull, and the arachnoid, that's the middle layer. And it's usually due to low pressure venous bleeding. All right. So these can usually come on, the presentation can come on slow as far as mental status changes. These are the things that happen to like a lot of elderly that fall, hit their head, okay? And they go to the hospital because they got their bell rung. They do a CAT scan, they look, they don't find anything, but they got this little bitty vessel in there that's bleeding, okay? A little vein that's bleeding, and over several days, the patient starts to get worse because that pressure starts building up, decreasing of consciousness or altered mental status. They go back and they find they have a bleed, okay? So subdural is usually a slow, it's usually venous in nature. Okay, so there are two types of subdural, and I just kind of talked about it. The acute, okay, immediately after the injury, that's when you have some altered mental status and all that stuff. Occult or chronic, that's the lady that's been having these issues over several days. Okay, an epidural hematoma. I can't talk anymore. Epidural hematoma is arterial or venous, the bleeding pools between the skull and the dura. Okay. So this one, it's usually rapid, profuse, and severe bleeding. So a lot of times this one's more arterial in nature because it bleeds a lot faster. Okay, so it bleeds a lot faster, small space, a lot of swelling occurs, increases intracranial pressure. Okay, and that's when we're going to see immediate altered mental status changing. And this one's usually, this is where you're going to see those Cushing's reflex or Cushing's triad a lot sooner. All right, remember heart rate goes up. I'm sorry, blood pressure goes up because your body's trying to perfuse because it's losing blood. Okay, it's losing pressure up here. So blood pressure goes up, heart rate goes down, and you have those weird breathing patterns. Okay, that's it. All right. I know I talked fast and went through a lot of stuff, but I hope this helps you guys. Um, any questions? I know there's only like 2 or 3 of y'all in here. Um, let's see, it's just Emily and Miranda right now. Do y'all have any questions I could clarify before I log off here? I'm going to stop sharing my screen. Okay. Get my chat box back up. All right, if y'all don't have any questions, I'm going to log this presentation off and hopefully it saves it in Canvas somewhere. Okay, wait. All right, Emily, you can key up and talk if that's easier, unless you type in something.
Okay, can you hear me?
Mm-hmm.
Okay. For the amputation, the finding the limb versus controlling the bleeding of, the amputation,
Uh-huh.
that was a question that was on our pre-test, post-test, and all that.
Okay.
So you want to find it said find the limb before you control the bleeding.
No, that's ridiculous.
Yeah, that was weird to me.
Yeah, no, absolutely. Stop bleeding first.
Right.
What was, do you remember what that was on?
It was for the book, I think, where it was on Canvas,
Right, like a
but one of the questions,
pre-test?
I think it was on the post test.
Post-test? Okay. If you
Yeah,
can find,
it said locate the limb before, like that was the right answer in homework because I got it wrong.
no, no. If you got bleeding, you're gonna stop the bleeding before you look for an extremity
Okay, yeah, that's
or
where I was
amputated part.
confused.
Yeah, no, but definitely take an amputated part to the hospital if you can find it, but you definitely don't want to delay care looking for it.
Right,
Okay, so
right,
yeah, if your patient's critical, you transport, hopefully fire department can find it or something like that, but don't delay
right.
care.
Yeah, it said find the limb first, and I was like, that doesn't sound right.
No, no. You won't have anything to attach it to if you don't stop.
Right. I was like, that doesn't make sense. All right, thank you.
Okay, you're welcome. That's it.
That's it.
All righty. Okay, all right, guys. Well, good luck on y'all test, and pay attention to those burn questions. Okay, make sure you understand what body part they're talking about: lower, upper, anterior, posterior, all that stuff, and use your rule of knots. All right, I'm going to.